Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
In this series, we will demonstrate a number of initial incision, flap elevation, and suturing techniques. In this demonstration, we will use disclosing solution to highlight the position and placement of initial incisions. We will first demonstrate the elevation of a full thickness flap by first making an incision over the crestal tissue down to and including periosteum. This incision must be retraced to ensure a continuous incision through periosteum from mesial through distal. We will also place vertical releasing incisions. In this case, the incisions will not be parallel, but will be oblique. The purpose of this flap is purely access and not repositioning of gingival tissues. The vertical releasing incision is placed beyond the mucogingival junction to take advantage of the elastic nature of mucosa. We will place vertical releasing incisions both on the distal and mesial of the buccal and lingual flaps. These incisions again are placed through periosteum in a continuous nature. Initial elevation of the flap should include sharp dissection beneath the periosteum using the scalpel both as a knife and as a periosteal elevator. Once the periosteum is totally incised and the flap is slightly movable, a periosteal elevator can be applied with gentle pressure under the periosteum to elevate the flap. And here we can see elevation of a full thickness flap on the lingual portion of this mandible. We would like to emphasize the use of scalpels to begin the elevation process. Sharp dissection offers the most atraumatic and controlled method to elevate a flap. We can now measure the thickness of the full thickness flap. In this case, measuring 3 to 4 millimeters and including oral epithelium, gingival connective tissue, and the underlying periosteum. We'll now demonstrate the elevation of a split thickness flap. The initial incision is exactly the same, running from mesial to distal, from crestal gingiva through and down to crestal bone. In this case, we will place 2 parallel vertical releasing incisions because we intend to apically position the lingual flap in this demonstration. The parallel nature of the vertical releasing incisions allows this repositioning. Once the initial incision is placed, the angle of the blade can be changed to undermine or thin the lingual flap. In this case, we would like to produce a lingual flap which measures 1.5 to 2 millimeters in thickness. Your assistant can elevate the flap with tissue forceps using gentle tension. This allows visibility for the operator to gently and atraumatically undermine the lingual flap, using care not to perforate the flap and to maintain an adequate thickness of tissue. As you can see, we are leaving a bed of gingival connective tissue between the suture blade and the underlying bone. In a periodontal procedure, this underlying tissue would normally be removed, leaving a ideally contoured lingual flap. The thickness of this flap is approximately 1.5 to 2 millimeters and can be compared to the thickness of the flap which lies to the buccal, which we will demonstrate as a full thickness flap. We will now make an incision below the periosteum to demonstrate the difference between a full thickness flap on the buccal and a split thickness flap on the lingual. The split thickness flap is ideally suited in production of the apically positioned flap where pocket reduction is anticipated. The figure-8 suture is widely used in oral surgery, but has limited applications in periodontics. We will demonstrate this suture at this time. The suture is passed from the oral side of the buccal flap to the tissue side of the same flap. And then the same process is repeated on the lingual flap. Again, insertion of the suture into the oral side of the lingual flap, through to the tissue side. The suture needle exits through the incision, and the suture is eventually tied on the buccal flap. What this technique results in is a portion of the suture passing through the incision both in a lingual direction and buccal direction, forming a figure-8. The crossover of the figure-8 occurs at the incision. The suture is tied tightly to approximate the buccal with the lingual flap. The knot is ideally placed either buccal or lingual to the incision. While this suture accomplishes apposition of the buccal with the lingual flap, it leaves suture material resting between the two flaps in the incision line. Again, this suture forms a figure-8, where the crossover portion of the figure-8 lies within the incision. Where primary adaptation of the buccal with lingual flap is desired, this intervening suture material is contraindicated. We will now compare the figure-8 suture to an interrupted loop suture, which is more widely used in periodontal therapy. In this technique, the suture needle is passed from the oral side of the buccal flap to the tissue side, but then is advanced through the lingual flap from the tissue side to the oral side. In the lingual flap, the suture needle is advanced from the tissue side of the flap through the gingival tissue to the oral surface. While the suture passes from buccal to lingual, it does not pass through the incision itself, but underneath it. The suture is tied with a typical surgeon's knot, usually by first making 2 clockwise turns with the hemostat, and tying down with an initial knot, followed by one counterclockwise turn on the suture, to secure the knot, followed by an optional clockwise turn to finalize the knot. The knot should lie either buccal or lingual to the incision line and can be cut approximately 3 millimeters from the knot itself. Here we can compare the interrupted loop suture on the right with the figure 8 suture on the left. The interrupted loop suture allows primary adaptation of the buccal with lingual flap. We will now demonstrate a horizontal mattress suture, in this case an external horizontal mattress. This suture is called a mattress suture because it allows the bulk of the suture to lie on tissue as on a mattress. This suture technique has definite advantages in situations such as bone grafting, guided tissue regeneration, or where preferential coronal positioning of a flap is required. The suture is advanced from the oral side of the flap through to the tissue side, and then is returned in the buccal flap from tissue to oral side. Hence, the internal part of the suture lies only underneath the buccal and lingual flaps, and suture material does not pass underneath the incision line itself, but rather external to the incision line. The same process is repeated on the lingual flap, either to produce two parallel suture lines or a crossover design. In this example, we will demonstrate parallel suturing. Again, the suture needle is advanced from the oral side of the flap to the tissue side, on the mesial first, and then is reversed in direction on the distal from the tissue side of the flap to the oral side of the flap. Again, the suture material lies exclusively internal to either the buccal or lingual flap and will not cross the incision to this point. However, as the suturing is completed, the suture material will lie external to both the flap and incision. Primary adaptation of the buccal to lingual flap is nicely accomplished with the suture material lying external to the incision. Again, the external mattress suture has definite advantages in certain clinical situations, including closure of distal wedges, closure of flaps over bone grafting material, and in other special applications. The suture is tied with a typical surgeon's knot, again using the typical sequence of two clockwise turns, followed by a counterclockwise turn, followed again by a clockwise turn, and is cut leaving a 3 millimeter suture tail. These three suture techniques can now be compared. First, the horizontal mattress on the right, the interrupted loop in the middle, and the figure 8 suture on the left. We'll now demonstrate closure of a vertical releasing incision with apical positioning of the lingual flap. The suture is always advanced through the movable portion, that is, the flap itself. We will be moving our suture from the movable tissue of the flap to the stationary tissue which surrounds the flap. In this way, we can let the suture determine the eventual position of the flap. We will deliberately position the suture needle apical to the initial placement of the suture in keratinized tissue of the surrounding tissue. We will be using an interrupted loop suture, closing and knotting in a similar fashion, and we'll observe the effect of this suture placement on the final position of the lingual flap. By tying at this position, we have determined the final position of the lingual flap approximately 3 millimeters apical to its original position. The elasticity of mucosal tissue allows the lingual flap to be positioned at this new dimension. This is the basic principle which underlies the apically positioned flap. Hence, vertical releasing incisions and closure of vertical releasing incisions in this manner is frequently employed with the apically positioned flap. We will now continue to suture the lingual flap using a sling suture, which will begin from the knot we have placed in the distal area. A sling suture allows preferential positioning of either a buccal or lingual flap independent of the other flap. Suture is placed in this instance in the lingual flap, is passed back through the interproximal area and is slung around the opposing buccal surfaces of the mandibular teeth. In this example, the sling suture allows the operator to position the lingual flap at a position independent of the buccal flap and to suture the lingual flap at a tension that is different from the buccal flap. This cannot be accomplished with an interrupted loop or other interrupted suture design. As you can see, we will be passing the suture tail first rather than toe first through the interproximal area. This saves time and effort in that the suture can be picked up on the lingual in a position which is close to its desired position for placement into the lingual flap. The suture is positioned below the papilla tip, 3 millimeters or more from the incision line, within keratinized gingival connective tissue. Suture is passed back through the interproximal area and is slung around or along the buccal surface of the adjacent tooth. The procedure is repeated in anterior areas until the lingual flap is completely sutured from distal to mesial. The lingual flap can be independently sutured by knotting the sling suture at its terminal end by simply looping the suture around the terminal tooth either once or twice, picking up a component of that suture and tying a secure knot in this location. However, before the knot is secured, the tension on the lingual flap should be checked to ensure that the lingual flap is in its desired location before the suture is tied. Here we can see the suture as it is slung along the buccal surface of these teeth. We will leave a small tail from the final loop on which we will place the final knot, like so. Hence, the lingual flap can be independently sutured. And if desired, the buccal flap can be sutured in a similar way under a different tension and at a different position. The sling suture is ideally suited to the apically positioned flap procedure. As you can see, the sling suture allows the lingual flap to rest at a position apical to its original position along the tooth surface. A periodontal pack will now be placed to secure this tissue at this position.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.